I think perhaps in a way the most important point I want to make this afternoon is that I don't think end-of-life care within the NHS should be treated as an additional service. It is integral to the service that the NHS provides. Therefore, Tom, you'll forgive me if I say, I don't actually think the activity in the NHS should be governed by a ring-fenced budget within the NHS. That is, the purpose of which is to provide end-of-life care. I want to arrive at a position where end-of-life care is commissioned and funded in ways that directly correspond to other NHS services. And indeed, where children's hospices was concerned, that was the intention of our proposal, is that, as many of you will know, children's hospices have very low levels of state-provided funding. If that £10 million recurrent grant available this year and next year were not to be continued in the subsequent year, there would be considerable difficulties for children's hospices in maintaining their services. But that is not the end point of what we want to achieve. We want to achieve a place where hospices, alongside other palliative and end-of-life care providers, receive resources from the NHS in relation to the NHS's commissioning responsibilities like other providers would. And that will be true for community palliative care providers, hospices, and indeed hospitals. And so to that extent, what I was saying, David and I were saying just before Christmas in relation to children's hospices has an exact parallel in relation to adult hospice care and end-of-life care. We want to develop a system where the resources of the NHS follows the referral and the service that is provided and does not distinguish between the characteristics of the care provider. So it isn't the case that if you get referred into an NHS hospital, the hospital will have to rise the tariff. If you get referred into a hospice, that the same resources will not follow into the hospice care or indeed a charitable community provider. So, and I know that there have been efforts through the end-of-life and giving people good access to good quality information is going to be integral to that. And indeed, from my point of view, that too is part of mainstreaming end-of-life care into the reforms we want to see in the NHS. Central to what we want to achieve in the NHS is the improving the quality and the relevance of the information that is being provided to patients. All the evidence is very clear from all over the world that we as a country may have a very centralised healthcare system. We may have one which is relative to many others, have a degree of equality in it. But as a consequence of those features, it also has a lack of responsiveness and a lack of good quality information to the public and patients about the service that is provided to them, who it's being provided by, why it's being provided, and what choices and opportunities there are to control healthcare. So we want to make sure that that quality of information and control is provided to patients at every part of their journey for whatever reasons, and that certainly should include, obviously, their journey when it comes to end of life. Now, from my point of view, also, as part of mainstreaming end-of-life care, we are going to have to be sure that the commissioners of services are accountable not only for the results they achieve, and we need to be clear about what we mean by results, but also very clear about the quality of service to be provided. I know that there are some commissioning guidelines available that are relevant to this. Clearly there are issues like the gold standards framework. What we need to do is to bring those together and make sure that on the commissioning side, we are very clear about what standard of end-of-life care we are intending to maintain. Now, from my point of view, I am not looking for ministers to be making those decisions. I am looking for the NHS board with independence on a day-to-day basis, with advice from the National Institute about the evidence base for the quality of services and what the key quality indicators are, what the evidence justifies in terms of commissioning, both for clinical effectiveness and cost effectiveness, to be able to look at that and to issue commissioning guidelines that make clear both to patients and to clinicians what quality of service should be provided. And that, I think, will help us in the process too, defining what results we're looking for. And then when it comes to providers, from my point of view, I hope we will get that plurality of provision, which clearly needs to be a long-term facet of NHS provision generally. Where end-of-life care is concerned, of course, we already have significant plurality. It's just that that plurality is not really given full opportunity inside the NHS to exploit the opportunities for integration. I know many hospices are thinking about how they can develop community services alongside their hospice-based care. I know many, like Curie, are thinking about how they can be a more holistic, like the Delivery Choice Programme, a more holistic provider of services at end of life. And both of those are terrifically important. And I think the structure that I'm talking about is one that will support that.